Hello, and welcome to a very special podcast that is part of a series I'm leading on diversity and inclusivity with CME Outfitters. Today's CMEO briefcase is entitled Racial Disparities in Cardiac Arrhythmia Care, a Call to Action. I'm Dr. Monica Peak, and I'm a professor of medicine at the University of Chicago. I'd now like to welcome Dr. Larry Jackson, cardiologist and assistant professor of medicine at Duke University School of Medicine. Dr. Jackson, I'm honored to have you joining us today. I'm excited about the discussion that lies ahead.
Good afternoon, Dr. Peak. It is an absolute pleasure to be here with you and your audience today, specifically to discuss this important topic, an area that I have built my research program and career on.
Well, we're excited to hear about all of that. Let me begin by starting with our learning objective, which is to integrate best practices to mitigate disparities in the management of cardiac rhythm disorders across race, ethnicity, and gender. But first, let's ask you, the audience, to give us your input on this question. African Americans or Black patients with atrial fibrillation have a much higher risk of stroke than white patients with AF. And the question is, at which rate? Is it 1.5 times higher, 3 times higher, 4 times higher, or 5.5 times higher? And I'll pause and let you all give your responses. Okay, so we see that we have some who have guessed correctly at 3 times higher. That is the correct answer. And so we're looking forward to hearing more about what Dr. Jackson can tell us more about this. Dr. Jackson, we know that there are health disparities in cardiovascular care. What about inequities specifically in heart arrhythmia care and wider interventional cardiology? I'm also really intrigued to hear about the atrial fibrillation paradox. Tell me what that means.
Absolutely. So, Dr. Peak, when we think about racial and ethnic and gender differences in arrhythmia care, the majority of our efforts has been focused on atrial arrhythmia, specifically atrial fibrillation, and then sudden cardiac death prevention in patients with heart failure with reduced ejection fractions. Now, with regards to atrial fibrillation, I want your audience to know that it is the most common abnormal heart rhythm in the world, and it is associated with an increased risk of stroke and systemic embolism by 4 to 5-fold. We know that Blacks cluster an increased number of risk factors associated with atrial fibrillation, including hypertension, including diabetes, including obesity and metabolic syndrome, including chronic kidney disease. But study after study, Blacks continue to have an overall significantly decreased incidence and prevalence of atrial fibrillation. And herein lies the paradox. And in fact, it is a double paradox. Blacks clustering an increased number of risk factors associated with atrial fibrillation, but having a decreased overall incidence and prevalence. But unfortunately, despite that overall decreased incidence and prevalence, Blacks have a higher rate of poor outcomes, which we will discuss shortly. So when we are thinking about explanations and theories for the AFib paradox, we should expound on a couple of different ideas. There's one idea about ascertainment bias, ascertaining or capturing atrial fibrillation. Maybe we are just not capturing atrial fibrillation at the same rate in Blacks compared to whites. There's been some studies looking at this by Prashant Bhave and Monica Chen, where specifically they analyze in Medicare beneficiaries, Black and white patients with cardiovascular implantable electronic devices. There you can monitor and capture all the episodes of atrial fibrillation that a person would have, but still that AF paradox still existed even in that study where Blacks had a significantly lower rate of atrial arrhythmias, including atrial fibrillation. Let's talk about survivorship bias. We know that whites tend to live longer than Blacks. We know that AFib, in terms of an abnormal arrhythmia, affects individuals more so as we age. So maybe due to Blacks dying earlier, we are just not capturing as much atrial fibrillation. The last idea to touch upon is the idea about potential genetic and ethnic specific factors. And I think Dr. Stamos and Dawood Darbar have articulated this in a way to suggest that there is a differential impact in some sort of ethnic specific factor, as well as an underlying genetic basis that is leading to this AFib paradox. So a lot to still disentangle with the AFib paradox, and a lot going on in terms of research inquiry into these genetic and ethnic specific factors. In terms of poor outcomes.
One question I have from the audience already, to just touch upon that one point, is how do we have any sense of how common AFib is actually undiagnosed in the African American population? So we know that it likely is. Do we have a sense of the prevalence of that? Like we know for diabetes, 1 in 4 go undiagnosed. Is there any sense of the magnitude of this for the African American population?
Yeah, it's hard and it's difficult, and we don't have the best information regarding undiagnosed atrial fibrillation. And it's tricky, right? Atrial fibrillation many times can be asymptomatic for a variety of people. And people's first presentation of atrial fibrillation may be a stroke. So unfortunately, we don't have the best data in terms of undiagnosed in this specific cohort.
Great. One other question I'll ask before you move on is, do African American patients with atrial fibrillation have a higher incidence of risks such as bleeding and stroke or valve damage due to cardiac ablation? So I know you're going to get into the interventional radiology, but while I have your attention, just know that that's a question that we have from the audience.
Sure. Just to speak on that briefly, there is data that will be coming out, but I think the audience will be surprised that these groups, specifically Blacks with atrial fibrillation, tend to do very good with catheter ablation, and may even have less long-term side effects after catheter ablation. So we can certainly talk about that as we move through the slides. Just in regards to the ERIC study, we saw that Blacks with atrial fibrillation had significantly higher, poorer outcomes, including a risk of stroke, cardiovascular disease, heart failure, and mortality. I believe, Dr. Peak, you had asked about interventional-based procedures. And, we have some data here to suggest that when we look at interventional cardiovascular procedures, specifically around structural heart disease, stroke reduction, and the prevention of sudden cardiac death, we see that we have not only racial and ethnic differences, but also gender differences. And this slide nicely details data from Al-Cooley and colleagues, where they looked at the national inpatient sample and demonstrate that the utilization of structural heart disease interventions specifically differed by race and ethnicity. And I think as we delve into these topics, the question is why this is happening. It may not just be an issue about referral from physicians. We have to consider refusal and why patients may be refused.
Excellent. So you just mentioned disparate care in life-saving cardiology procedures. What can you tell us about procedures such as catheter ablation for atrial fibrillation, and why is this important?
Yeah, I would say that disparities in catheter ablation, and really when we talk about catheter ablation, I like to put that in the context of rhythm control, right? Restoration of normal sinus rhythm with either antiarrhythmic drugs and catheter ablation, that defines sort of rhythm control. And so these disparities are notable. Why are they notable? We know that it is important to establish rhythm control early in patients with atrial fibrillation, and that restoration of normal sinus rhythm has been linked to a lower risk of adverse cardiovascular outcomes. We've seen this in the East AFNet4 investigators. Now, the study you have detailed on the slide there it's a great study. It's from investigators at the University of Pennsylvania. And so what did they do? They evaluated cumulative rates of antiarrhythmic drug use and catheter ablation. Those are both rhythm control strategies. The patients had paroxysmal atrial fibrillation, and they looked at who's getting rhythm control really as a function of race, ethnicity, and socioeconomic status. And this is data from the Optum Clinical Informatics Data Mart. So in the multivariate analysis, what did they see? So if you were Black or you had a lower median household income, you were less likely to get a rhythm control strategy overall. Additionally, if you were Latinx coupled with a lower median household income, you were also less likely to get catheter ablation. And so, we've seen this in several different studies, and it's important because, as we'll get into later, catheter ablation may be beneficial in racial and ethnic groups. And we have to really drive home the point that early rhythm restoration with rhythm control leads to decrease in poor outcomes.
Excellent. One of the best ways that we have to illustrate really anything in clinical medicine, but also structural and interpersonal inequities in cardiac care, is to look at the needs of some individual patients. So, Dr. Jackson, please take us through the first patient case.
Absolutely. We have, for the first case, Mr. Roger Hughes. He is 65-year-old African-American male. He's got a history of recurrent paroxysmal atrial fibrillation. Mr. Hughes is doing well with weight loss, but is still overweight. He does have a history of high blood pressure, albeit it is well controlled. Mr. Hughes also has a history of obstructive sleep apnea, but is compliant with his CPAP machine. In terms of medication therapy, he is on flecainide, which is an antiarrhythmic, part of that pharmacologic rhythm control strategy. He has a rate control agent, specifically metoprolol succinate, and he is on systemic oral anticoagulation with warfarin. Additionally, Mr. Hughes is presenting to follow-up. He's having recurrent palpitations. He is short of breath with a moderate amount of exertion. And he started to get to the point where he thinks he's about to actually pass out. Now, Mr. Hughes has been tried on flecainide before in terms of a pillet and a pocket approach. And unfortunately, that's just not being all that effective at this time. We know he has a normal heart, specifically a normal ejection fraction, and no history of valvular heart disease.
Okay. Before we discuss the best care options for this patient, let's ask the audience a related question. Which of the following recommendations is a best practice guideline for the treatment of atrial fibrillation? First, antiarrhythmic drug therapy for doses. Antiarrhythmic drug therapy dosage varies by race. Second, direct acting oral anticoagulants, DOACs, are typically recommended over the use of warfarin. Third, or C, elderly patients should not take anticoagulants to avoid bleeding risks. And last, rhythm control therapy should be taken with antihypertensive medication. Okay, so we see that some have the right answer as far as DOACs, and that is something that myself as a primary care physician use all the time, something that is part of my routine practice. And I remember us making the transition from warfarin all the time to now warfarin in extenuating circumstances for specific populations of patients. And so they really have revolutionized how we think about not only atrial fibrillation, but lots of other indications for anticoagulants. So Dr. Jackson, do you want to reflect any of your thoughts about the audience polling?
Sure. And I think, it's a good question. And I think when we look at direct acting oral anticoagulants, per the guidelines, they are preferred over warfarin. And I think in the context of managing AFib, let's spend some time talking about stroke reduction. We have warfarin, we have the direct oral anticoagulants, we have left atrial appendage occlusion. Now, with respect to warfarin, our audience really needs to understand that Blacks with atrial fibrillation on warfarin have some of the highest risk of intracranial hemorrhage compared to other racial and ethnic groups, okay? Additionally, the dosing of warfarin may be different, right? Blacks in general require higher doses of warfarin to maintain an INR between 2 and 3. What is the reasons for that? Well, some of this has to do with genetics, and specifically single nucleotide polymorphisms in the cytochrome P450 system, specifically CYP2C9, as well as vitamin K, epoxide reductase complex 1, an enzyme that metabolizes warfarin. So we should understand that warfarin requires higher dosing in Blacks in general, but that the risk of intracranial bleeding in the head is significantly higher in not only Blacks, but also Asians and Hispanics compared to whites, okay? When we talk about direct oral anticoagulants, these indeed are preferred over warfarin and are embedded in the guidelines as such. And why? We know that DOACs have more consistent oral anticoagulation. They have less food and drug interactions. They do not require monitoring, and they have significantly lower rates of intracranial hemorrhage compared to warfarin. We studied DOAC administration in patients with non-valvular atrial fibrillation in the ORBIT studies, specifically a colleague and friend, Dr. Yutube Essien and I. And what we found is after adjustment for several different things, including clinical characteristics and socioeconomic status, Blacks were significantly less likely to be on direct oral anticoagulants. And if they were on warfarin, they had poor quality of warfarin management, meaning they were less likely to be in the therapeutic range. Additional studies from ORBIT have looked at mineralocorticoid receptor antagonists, and the data is somewhat equivocal as to whether they reduce AF progression and stroke. So more studies are needed with respect to whether we can use that type of therapy to reduce AF progression or stroke. We spoke a little bit about racial and gender differences in the use of another stroke reduction therapy called left atrial appendage occlusion. We know there is underutilization in racial and ethnic groups, and we know that women who undergo left atrial appendage occlusion tend to have higher rates and complications.
So let me just intervene and ask a question that came from the audience, and you're beginning to address some of that, which is, should race be a factor in guidelines for management of atrial fibrillation? And they also said for hypertension, but you're talking about some of the ways in which race affects how medicine may or may not be interacting with certain patient populations at the genetic level. And so it may not be the brown skin per se, but it's the genetics. And so I know that we frequently have had genetic testing when we're thinking about anticoagulation to try and make sure that we get it right. And then in general, how we think about populations who may be more hesitant for medications. And another question was asking about how do we address some of the patient hesitancy for some of the interventions and things. And so can you talk a little bit just about what your thoughts are about race and treatment and guidelines?
Yeah, it's, I won't say it's a touchy subject, but it is certainly interesting and one that deserves, I think, some conversation. And, I think the majority of us in this work think of race as something that's socially constructed and not necessarily a biologic or genetic basis. And I tend to lean more on genetics and ancestry, and potentially trying to get more data and understand those things as potential drivers why we see differences in metabolism of drugs and potential effects and side effects or efficacy of procedures. So I don't know if race, as we define race, is the best way to go, or whether that should be inculcated into the guidelines. I think much more work is needed at the intersection of genetics and ancestry, and how social determinants of health are really playing a part into a myriad of these different things that we see as a function of what we call race or ethnicity.
Excellent. Thank you. Go ahead.
Additionally, when we look at oral anticoagulation therapy, as we have kind of stated that, there is poor quality with warfarin and other vitamin K antagonists. And really, I try to counsel my patients, specifically those who are Black and Hispanic, of the benefits of direct oral anticoagulants, specifically less intracranial hemorrhage, more consistent oral anticoagulation. But we must remember that if we look at the data that approved some of these common drugs that we are prescribing our patients, Eliquis, Xarelto, Pradaxa, if you take those 3 trials that show non-inferiority or superiority compared to warfarin, what do you get? Over 30,000 patients, less than 2% of them were Black. And then when we look at reporting of Hispanic ethnic patients in those studies, it is woefully incomplete. And so the question begs, what do we know about safety and efficacy of these drugs in new populations? We think they work, and based on theoretical issues, we think they are better for patients of racial and ethnic backgrounds. But as future oral anticoagulants, factor 11, factor 12 inhibitors come down the road, we need to ensure that our populations are adequately sampled to understand true safety and efficacy.
Thank you. That's so very helpful.
Sure. Go ahead, Dr. Pete.
I'm just going to mention our next patient case. Do you want to go ahead and lead us through that?
Absolutely. Our next case is Miss Davis. So she is a 48-year-old African-American female. She's a history of a non-ischemic cardiomyopathy. Was diagnosed 4 years ago. She has a very low EF. She has normal coronary arteries on cardiac catheterization. She's on great meds, including Entresto, including spironolactone, including metoprolol succinate. When we look at her electrocardiogram, she's in normal rhythm with a wide QRS and a left bundle branch block pattern. Her symptoms are shortness of breath with exertion, and sort of waking up at night with shortness of breath and inability to catch her breath. So she was actually referred from Heart Failure Clinic at Duke to consider additional advanced therapies. And so when we look at Mrs. Davis' case, she is on great medical therapy. She's been on such for greater than 90 days. She's had several echocardiograms that showing that even despite medical therapy, her ejection fraction has not improved. When we talk about symptoms, and she's a class 3 NYHA heart failure stage, she's got marked limitation in sort of mild to moderate activity. She's a non-ischemic substrate. She's got sinus rhythm, and she's got a left bundle branch block pattern. So this is a patient who, in my mind, meets guidelines not only for sudden cardiac death prevention with a defibrillator, but also potentially cardiac resynchronization therapy, which has the ability to improve her exercise tolerance and as well as improve her ejection fraction.
Great. So placement of heart rhythm monitors and implantable defibrillators, implantable cardioverters and other devices can help prevent morbidity and mortality in patients with AFib. Dr. Jackson, can you take us through some of the data on these interventional procedures?
Sure. I think with respect to AFib, we know that implantable loop monitors are certainly better than standard of care We get this data from the Crystal AF trial that showed these monitors are significantly more likely to capture atrial arrhythmias. And why is that important? If we capture AFib, we have guideline indicated stroke reduction therapies that can help decrease the rate of stroke and systemic embolism and hard outcomes. I think we also, with this case, have to highlight the point that there are gender differences and disparities in terms of who's getting these implantable heart monitors, specifically ICDs. We know that historically that females have been poorly represented in these trials. They're less likely to receive ICD therapy, and we know that ICD therapy works for both men and women. And so when we think about Ms. Davis's case, we really have to understand and really give her all the information so where she can make an informed decision about ICD therapy. And this is an important point and segue to bring up specifically with ICDs, and that while there is underutilization, it's unclear what is driving that. Poor referrals or patient refusal. I think patient refusal is a significant part of the equation that is not talked about. And that's why informed decision making on risk and benefits of ICDs is so important to our patients.
Excellent.
So just to update you on the case with Ms. Davis, she is on guideline directed therapy. She meets qualifications for sudden cardiac death prevention. She meets qualifications for CRT therapy. These are both therapies that I would offer her. And, we've highlighted racial differences and gender differences in ICD therapy. And the VIVID trial, which is ongoing, seeks to help patients make informed, better decisions about ICD therapy through patient decision support tools.
Excellent. Now, we're going to do the third and last patient case. In the interest of time, I think we might skip the audience poll and just give them the answers.
Sounds good. So Mr. Adam Kohala, he's 36. He's a native Hawaiian. He has a history of occasional hypertension. He presents tachycardia, 190 beats per minute, complaining of shortness of breath, dizziness, and chest pain. He is diagnosed with paroxysmal atrial fibrillation. He's got high blood pressure. He's a little overweight. He's got a CHADS basket 1, a family history of valvular heart disease and stroke. He's on no medications besides muscle supplements that he states he's been taking. And if we look at the question, Dr. Peak, I'll let you further explain the question.
Okay. So the question is, Native Hawaiians and Pacific Islanders have a higher risk of stroke, primarily due to which factors? A, undiagnosed atrial fibrillation and or lack of patient adherence to treatment for AF. B, genetic factors, including cardiomyopathies. C, a higher prevalence of hypertension and type 2 diabetes. Or D, higher rates of alcoholism and smoking. And the answer is C, a higher prevalence of hypertension and diabetes. So, as mentioned in the question above, the data shows that there are disparate rates of cardiovascular disease, including heart failure and stroke in people from the Native Hawaiian and Pacific Islander population. So, Dr. Jackson, can you tell us just a little bit more about this?
Sure. I think it's a unique group that has not gotten the attention it deserves. And I think with respect to arrhythmia management, we have an extreme paucity of data in Native Hawaiians and Pacific Islanders. And unfortunately, and additionally, these groups have been previously classified as Asians in studies of cardiovascular disease and cardiovascular risk factors. And that's certainly not in alignment with descriptions from the Office of Management and Budget. Specifically with Native Hawaiians and Pacific Islanders, they cluster very high burdens of cardiovascular risk factors compared to whites. And they have very different risk factor profiles compared to Asians. So they are very similar to Blacks and Hispanics in having a higher prevalence of diabetes and obesity and hypertension and metabolic syndrome. We know that also that Native Hawaiian and Pacific Islanders are more likely to experience ischemic strokes potentially decades earlier than whites. So we need much more inquiry into this specific select subgroup to understand how to mitigate some of these poor outcomes that this groups are experiencing.
So This patient is an example of a younger patient who has signs of atrial fibrillation. And so, Dr. Jackson, how does this occur? And is care for younger adults with atrial fibrillation any different than care for older adults?
Yeah, unfortunately, thank you for the question, Dr. P. Unfortunately, we are seeing patients younger and younger come in with atrial arrhythmias. A lot of it is risk factors or poor control of risk factors. A lot of it is in environmental interactions. We have to treat Mr. Kohala the same way or think about the same things that we do for other patients. That's specifically stroke reduction and his risk for stroke reduction, and that's potentially rhythm control. Mr. Kohala has a CHAS-VAS score of 1, and while he is on the cusp for anticoagulation, I would argue that a CHAS-VAS score of 1 represents a real risk. And we have to think about, what are we trying to prevent here? We're trying to prevent strokes. AFib strokes are more disabling and more likely to cause you to die than non-AF related strokes. So I would have a serious conversation with him about initiating systemic or anticoagulation. We'd have to discuss things such as risk factor modification, his weight, his control of his blood pressure, but we'd also have to rule out common things, including structural heart disease and potential electrophysiologic phenomenon like WPW, to make sure those reversible things can be fixed that would lower his risk of future atrial arrhythmias.
So you touched on things that you would be asking him about before you started asking about some of the things around structural heart disease. One of the questions that came in is, what is the best way to ask heart arrhythmia patients about sort of the broad range of social determinants of health that may be affecting their care? And so when we think about obesity, for example, much of that is a function of their structural environment, their social and structural environment. And how do we begin to tap into understanding these things more holistically to be able to address them with our patients?
Yeah, it's a great question. And I look at things like this as being, a team approach being needed. And, I think you're right. We have to understand things about social networks and things about health literacy and things about education and nutrition and finances, and seeing that specifically is affecting how we manage and how we treat our patients, specifically with atrial arrhythmias. And it takes time, it takes effort, it takes a team approach. I frequently find myself speaking specifically in my outpatient clinic in the underserved area of North Carolina, speaking with primary care providers, understanding and developing a relationship there where we can better inform and treat our patients, because the risk factors and treating those risk factors are really some of the best bang for our buck that we can get with atrial arrhythmia. Can't necessarily change our genetic makeup, but a team approach centered on risk factor modification and understanding how we can improve access, improve health literacy, improve nutrition, some of these social determinants things is very important. It's not easy. And I think it takes almost a village even for just one specific patient.
Excellent. So Dr. Jackson, what are some action steps and best practices that we as healthcare providers can take to help prevent and mitigate disparities in heart rhythm disorders?
Yeah, I think health providers, physicians, advanced practice providers, nurses, to the best of our ability, we really have to inform ourselves about therapeutic options, whether it be procedural and pharmacologic for our patients. We really have to be informed about the risk and benefits of those, so we can articulate those to our patients. And we obviously have specialty care and adult cardiac electrophysiology, but there may be barriers within the health system to getting to that level of care. Mm-hmm. And so, understanding, at least at the basic level, procedural and pharmacologic interventions that can be used to treat atrial fibrillation is huge. The second thing I would say is risk factors, and modifying those risk factors, right? If we have a patient that is so overweight, poorly controlled diabetes, not on CPAP for obstructive sleep apnea, poor control of high blood pressure, I can do all the ablating till the cows come home and they're still going to have recurrent atrial fibrillation. So we have to understand we can't control genetics, but we have to tackle risk and tackle these cardiovascular risk factors that are associated with AFib.
And let me just jump in. You had mentioned some of the barriers in the first bullet around accessing some of these issues to care within the healthcare system. And so some of that, we've had some questions about healthcare bias that may be part of that barrier as far as helping to guide or not guide patients to goods and services or clinical decision-making. And so what are your thoughts about that and how we might, as part of thinking about these best strategies, make sure that the clinicians and the teams that you're referring to as a team approach, that we all are on the same page and trying to do our due diligence in mitigating our own personal biases?
Yeah, such a challenging topic. And I think when we think about disparate care, I think we have to think about the provider. I think we have to think about the patient. I think we have to think about the health system, and implicit bias or implicit social cognition is certainly an aspect of it's an idea we have to think about. What's the best way to eliminate that? Is a one-time training going to fix that problem? I would say no. We need repeated sort of hits and touch points about understanding our own implicit biases and how that is affecting our patient care. So I think that's one issue around many of potential barriers toward patients receiving equitable heart rhythm care. I don't know if I have the best answer. I know we need to think about and develop interventions that aim to address implicit bias, but to begin to offer them at multiple touch points throughout the year, whether that's quarterly, whether that's every 2 or 3 months. I'm not sure, but it certainly is a driver, something we certainly have to think about, but we have to keep that in context with other health system issues and as well as other patient-related barriers.
Great, thank you. All right, I'm going to let you move ahead.
Sure, and I would say to the group, as we sort of wrap up here, it's all about risk and thinking about risk of AFib and what puts our patients more at risk. And, traditionally, we have numerous things that are associated with atrial fibrillation. We do have now risk scores, including CHA2DS2-VASc, including Framingham and Charge AF, which are helpful in expounding on the risk of atrial fibrillation in our patient cohort. I think there was one question as to whether race or ethnicity should be used in the guidelines. So we've actually looked at this in terms of the CHA2DS2-VASc score, in terms of preventing stroke and assessing our risk for stroke. And it's not, and in the literature is clear, when you add race or ethnicity, whatever that means, to the CHA2DS2-VASc score, it actually increases our fidelity with accurately giving patients their risk of stroke and systemic embolism. But there's a lot to this entangle there. Is it race driving that? Is it the genetics or the ancestry that underlie those ethnic and racial patterns? So we have to consider risk, and we also have to understand monitoring and how monitoring can help us, and how monitoring is needed specifically in the context of atrial fibrillation, which is a rhythm that can be asymptomatic, patients feeling no symptoms, or present itself with a myriad of symptoms, including chest pain and shortness of breath and passing out. So we have to use all these tools, monitors, risk assessment, risk factor modification, to not only help and diagnose atrial fibrillation, but to treat and better inform our patients.
Mm-hmm. Excellent. All right. Well, thank you so much, Dr. Jackson. This brings us to the takeaway goals that each of us can play a part in implementing to help end disparities in arrhythmia care in the United States. Our SMART goals today are to identify inequitable pathways in prevalence, screening, and management of CVD and arrhythmia disorders in racial and ethnic minority populations, to integrate best practices and guidelines to account for structural racism in prevention care and management of medically underserved patients with cardiac rhythm disorders, to implement effective and timely clinical interventions to prevent major causes of morbidity and mortality in minority patients with cardiac arrhythmia disorders. We've received a number of questions already, and you can keep submitting your questions and comments by clicking the Ask Question tab. You can also email us at questions@cmeoutfitters.com or tweet to @CME Outfitters. I'm going to take one. We have so many questions. I'm just going to take one or two really quickly. So there's a question about, so this, two questions that can be answered quickly. Do you encourage atrial fibrillation patients from minority populations to get involved with clinical trials? And if so, how do you broach that subject with them?
I do. I tell them that we are woefully underrepresented in clinical trials. And for future populations that are racial and ethnic background, if we are going to understand about safety and efficacy of drugs and procedures, we need more participation.
Next question. I noticed the patient in the first case was on a beta blocker. Is this the best agent for hypertension in a Black patient? I've heard some reports that beta blockers are not as effective in this group.
While I am not a hypertension specialist, I would say there are probably preferred agents other than beta blockers. I myself have had hypertension since the age of 19. And so typically there is some genetic underpinning of sort of salt metabolism. And as such, diuretics such as thiazide diuretics tend to help African-American patients more so than other milder sort of affecting antihypertensives such as beta blockers.
And last quick one, how do we manage the risk benefit of the high rate of stroke that may require a higher dose of anticoagulant, or is that higher dose only with warfarin? And thinking about the DOACs.
Yeah, DOACs have consistent dosing that is really based on primarily renal function and some other things. So this differential dosing pattern that we see is pretty much restricted to warfarin and other vitamin K oral antagonists that we don't really use as much anymore. So the DOACs have consistent consistent dosing that is really driven by renal function, in some cases age and weight.
Mm-hmm, mm-hmm. I keep saying one more, but you're doing so good at answering so quickly. So one last question. In AFib patients who are young, how long is it safe to watch and wait before prescribing treatment? And at what point should younger patients be treated for AF?
Yeah, this is a challenging conversation, not just with young patients, but also all patients with AFib, because they start off with a little AFib. We call that paroxysmal. Mm-hmm. And unfortunately, even a little AFib begins to change the atrium in terms of fibrosis and how the atrium contracts. And those changes, which are deleterious, just lead to more AFib. And hence we say AF, atrial fibrillation, begets more atrial fibrillation. And I really counsel patients on that, hey, if you're having paroxysmal atrial fibrillation, we really need to think about rhythm control strategies early. And so I'm quite aggressive with discussing that with patients. I've ablated patients who've been in their 30s, who've been in their low 40s, and along with the risk factor modification, they've had great results. But if you sit on atrial fibrillation, you're going to get to a place where it becomes harder and much more difficult to control and manage.
Excellent. Thank you so much. This has been such a great session. Please join me here at CME Outfitters for our upcoming briefcases, where you'll hear more wonderful people like Dr. Jackson and activities with more action steps against health disparities. In particular, 2 of our upcoming briefcases will examine diversity and inclusivity in 2 important areas: oral health and dermatology, particularly melanoma. We'll be adding new content every month, and we really want to hear from you, our audience, on what you need so we can make an impact on these important issues. You can find out all about the upcoming live events and view previous ones on the DNI Hub at the link here. Please remember to collect credit for this activity using the Apply for Credit button that's currently on your screen. And again, thank you so much, Dr. Jackson, for your input today. Thank you for our audience for all the work in providing equitable and holistic care to all of our patients around the globe. It's just an honor and pleasure moderating these sessions, and thank you for having me.